Now, there's a huge interest from our patients in these so-called chemo-free. Of course, we could spend the whole time defining what we mean by chemo-free. But there is a huge interest, not just from clinicians, but from our patients themselves in these chemo-free approaches. Do you personally believe that we should be building these on top of the platforms we have, or do you see the future potentially as moving towards chemo-free regimens?
I think there's multiple strategies. As I mentioned, achieving a complete remission, and probably even better than this, a molecular remission in mantle cell lymphoma matters. So building up with what we have, we know that works. For example, hydroxytherapy containing regimen in a younger population. Can we add something either in combination or sequentially based on the MRD status to build up on this and improve the benefit in that situation? In the elderly population, either continue to build on a bendamustine rituximab arm as we discussed, backbone as we discussed, or to try to develop triplet or doublet in a combination setting. It is actually some very interesting, obviously the data on lenalidomide in a relapse refractory setting where the response rate is 30%, basically with 8 to 10% CR, and quite durable for a very heavily treated population, so provides an option of an oral agent. But combining with rituximab, this has now been piloted in a frontline setting with very impressive results that will be updated today, and starting to build up on this doublet in a chemo-free, as you discussed. And the question is that what are going to be the patient population that will best benefit from that, and what is the next doublet next agent we need to add to that?
So you're absolutely right. I mean, the interest in this so-called R-squared regimen, exploiting the biological activity of lenalidomide, which we had all postulated should work very well with an antibody in terms of, a synergistic activity between the two agents, is indeed being borne out not only in follicular lymphoma, but now we're also seeing in mantle cell lymphoma. So where do you, so what do you think first of the R-squared data, or the Revlimid rituximab data in mantle cell lymphoma versus conventional chemotherapy, and what are the types of patients that you think may be the people who would benefit most from this approach?
So I think you alluded, and you actually did part of a similar work that showed why lenalidomide is important to restore the immunological synapse, etc., in low-grade lymphoma follicular, but also in CLL and mantle cells. It's going to be the same. So the data is very impressive. It's not a very long follow-up, but the progression-free survival was very impressive. It's obviously very well tolerated. There was rash and myelotoxicity as expected. But although the patient population had basically 1/3 low risk, 1/3 intermediate, and 1/3 high risk, there was no difference in terms of response rate and outcome in that setting. So this provides really something interesting, particularly in this older population where the benefit of standard therapy, I'm not sure is really going to continue to persist.
So in terms of who you would, on the basis of this data, start to think about where, once it's approved in the frontline setting, where these sorts of regimens fit versus the other standard chemotherapy approaches that we have and the other agents that are emerging?
So we tend to dichotomize, younger and older based on the age limit, which obviously is very arbitrary, and I think we have to shy away from that. The problem is that we don't have good biological markers to really identify the patients who are truly unstable, difficult mantle cell lymphoma. We are starting to do this. There's interesting data we're presenting, the European presenting, are representing also from our institution, with high-perceived low-dose intensive therapy and transplant, and the patients who are p53 mutated actually really don't do well with that. So those are patients that have bad biomarkers that actually potentially could benefit better from a non-chemotherapy option from the get-go. Otherwise, on the other end of the spectrum is the older patients who are non-chemotherapy fit. And I think that will provide a perfect opportunity to treat these patients in the outpatient setting.
Now, of course, we already mentioned this issue about patients themselves looking to be trying to think about a chemo-free regimen, and of course we're saying that can fit well with the elderly patients for whom we don't have good options. What's the advice you give to a younger patient who would be fit for more aggressive regimens that comes to you and say, look, I really don't want to have conventional chemotherapy? Where do you think it fits there?
I think the data is very compelling so far, but it's still not a very long follow-up. And I truly believe, although there were some CR, we need to look at more follow-up. We don't really know how patients will behave once they progress after this. And then because given the nature of a chemo-resistant disease, at least with cytotoxic exposure before, it's a little bit challenging. So I think that if you have a strategy that can really achieve a molecular CR in patients with mantle cell lymphoma in younger patients, they will likely benefit and have a longer benefit in the long run. In a younger population, what I think would be more interesting is that continue to build up on what we know works against cytarabine-containing regimen to achieve a deep response, early molecular CR shown by European group that matters for the survival. But also in a patient who do not achieve, and that's being looked at in trial now, in a patient who don't achieve an MRD negative, can we then use those biological agents to bring them into an MRD negative status? And then that's where they're going to be more helpful.
Sure. Now, of course, the other agent recently approved in mantle cell lymphoma is ibrutinib. So, again, another important drug. Do you see a rationale for combining these sorts of therapies?
Yeah, this is already, it's a very good point. This is already being looked at, and we'll see some early data at this ASH. We have studied a study looking at R-square ibrutinib in the context of relapse refractory mantle cell lymphoma. As we learn, I mean, talking about chemotherapy-free, as you said, we learn of these regimens that are probably easier to the patients because it's oral regimen, it's outpatient, it's easier, doesn't have the classic side effects of chemotherapy. But as we start to learn to combine them, we can see more rashes, immunological phenomenon, and then sometimes that brings some toxicity that we kind of have to learn more on what's the best way to combine them.
So on that note, for those people that might start to think about, as these agents become more widely available for use, so what are the things that you look for when you're using lenalidomide-based regimens in treating mantle cell lymphoma? What's the toxicity profile that people should be aware of and look out for?
So typically lenalidomide is well tolerated, and we have patients up to 2 or 3 years on a pivotal trial, and then there's extensive experience from the previous trial. When you pull them together, what's interesting is that the response rate remains similar. And the durability is also impressive regardless of the prior therapies, subset analysis that we are presenting also at ASH, including some responses in the high KXC7, not as durable, but still some PRs in that setting. And the, the treatment is relatively well tolerated, and pretty much what physicians are expecting are familiar with in the context of multiple myeloma, with basically myelotoxicity, but easily manageable.
So very different from the experience of using the drug in CLL, where it was just not possible to use the kind of standard myeloma dosing without very significant hematologic toxicities. That's not been your experience in mantle cell lymphoma.
Correct. We haven't seen, I mean, obviously some dose reduction, but we haven't seen overall. This is really well tolerated, and then you can do some short interruption, growth factor support, etc. But usually we start at the same dose, and be able to continue patients on treatment. And patients obviously get on DVT prophylaxis, and outside of this, we haven't seen really significant toxicity.